Good morning. Good morning, everyone, and welcome to our webinar this morning. My name is Mehran Massoudi, and I'm the Regional Health Administrator for the Office of the Assistant Secretary for Health here in Dallas, Texas, Region 6. And it is our, we're very excited to have you here today. And we are hosting this webinar with Mr. Carl Berry of CCRC, and he'll later on talk about the organization before we introduce our speakers. So Bill, next slide, please. I'd like to just talk about briefly about the 10 regional health administrators within the Office of the Regional Health Operations who are the RHAs across the country in the 10 regional offices. Office of the Regional Health Operations mission is to provide regional coordination and support for departmental public health initiatives and accelerate implementation of public health policies. ORHO is dedicated to promoting and advancing the public health and safety of our communities, focusing on the underserved and vulnerable to reduce health disparities. ORHO has 10 regional offices across the nation. As a senior federal public health official in the region, the RHAs, Regional Health Administrators, perform essential functions for the Department of Health and Human Services in three major areas: prevention, preparedness, and agency-wide coordination. Next slide, please. We are here today mainly because of the Surgeon General's call to action, the most recent having to do with misinformation. On July 15th, 2021, the Surgeon General had issued an advisory for individuals, families, and communities, educators, health professionals, journalists, technology platforms, researchers, funders, and foundations and governments. And later, on November 9th, released a toolkit for healthcare professionals, teachers, and school personnel, and faith leaders and trusted community members with very helpful visual guides to help with this process and also exercises. We know throughout history that there has been a history of misinformation related to many diseases. These are just some examples: HIV, AIDS, and Ebola. There are many others, and I'm sure that our speakers will be talking about those. Next slide, please. What I'd like to talk about is just briefly what misinformation could look like. What I like to explain is misinformation can sometimes be spread intentionally to serve a malicious purpose, such as to trick people into believing something for financial gain or political advantage. This is usually called disinformation, but many people who share misinformation aren't trying to misinform. Instead, they may be raising a concern, making sense of conflicting information, or seeking answers to honest questions. There is a lot to be said about the context of what the information that is being shared and how that can change the interpretation of the statement. So what you see here is that we have two columns: common types of misinformation and common types of disinformation tactics. These are by no means totally exhaustive, but it gives you a flavor as to the types and kinds of tactics and types of misinformation that are out there. And quotes that's there: a lot of misinformation isn't completely false or fake. It's actually information or imagery that lacks context, something that has a kernel of truth to it. It's much more believable. And I'm sure that Dr. Hotez, throughout his presentation, will be referring to some of these concepts. Next slide, please. And again, why misinformation is unknowingly shared. This is a figure that's adapted from the community toolkit for addressing health misinformation, from what I referred to from the Surgeon General's toolkit, that the call to action. As you can see, all humans are susceptible to sharing misinformation. We care about our loved ones, and we want to keep them updated on new information to protect them from harm. COVID-19 has challenged the scientific field to stay abreast of the evolution of the virus and the best recommendations to give the public on how to stay safe while recognizing the need for connectivity to others and the mental health impacts of quarantine and lockdown measures. Evolving science has created opportunities for misinformation to fill in the gaps of what we don't know or discredit what we do know. In the image above, what you can see that every reason for unknowingly sharing misinformation aligns with the circumstances of the COVID-19 pandemic. The pandemic has created a perfect storm for misinformation to spread far and wide. So you can see COVID-19 can be fatal. So as a result, we want to protect the people we care about. We are socially isolated from others during the pandemic, so we want to feel connected to others. Because of the fact that the science is evolving, we're learning more and more every single day. And I'm sure that both Dr. Hotez as well as Dr. Cantor will be talking about the new COVID variant, Omicron, that is evolving. So we're learning something every day. So therefore, we feel like that we have new information that others don't know, and therefore we need to share that. So again, so on and so forth. And therefore, there's the information problems that we have. Next slide, please. And now I'd like to pass it over to my partner, Mr. Berry. I have him offer up some reflections and considerations before we pass it on to our next speaker. Carl, please.
Good morning, everybody. I am used to technical difficulties, so I'm on the phone because my desktop got kind of persnickety. But first of all, I want to welcome all newcomers to their first CCRC event. A little bit about CCRC is that we are about awareness. We promote events that inform, inspire, and can impact our community. We also have weekly TV and radio podcasts, and everybody that's registered here today will get a rebroadcast, whether they attend live or not, and it will be rebroadcasted several times in the next 6 months. So you can look for this and send it to your friends. And we believe, as always, with CCRC, you will discover an event that is unlike most others. You're going to hear a disclaimer. We're going to claim that right now. For those of you that are familiar with CCRC, welcome back. We're going to address a much needed topic, and in place of flyers, I am just making a brief announcement like I'm doing right now. And we've chosen to offer our traditional advice. You old timers, I'm gonna apologize, but I'm gonna repeat this. I was a sales trainer with AT&T and then owned my own retail business 18 years after I left there. And we used material that was designed for professional buyers to find the advice that was effective to help buyers make a decision. So here's the advice I give you. 3 things. Number 1, try to erase all predetermined beliefs. Number 2, new information merits a new decision. When I sold sofas and they told me they didn't like sleepers because it was uncomfortable, and then I explained to them why my sleepers were not uncomfortable, I was told, well, now it's a new decision. And then number 3, one of my favorite quotes comes from a guy named Herbert Stevenson. He coined the phrase survival of the fittest, but he also coined the phrase, there was a bar against all knowledge. It can keep you in total ignorance, and that is contempt prior to investigation, which basically says you can't trust anyone, including me, and even my friend. I like and respect Captain Masudi, but he's a Steelers fan. So you always got to take everything with a grain of salt. I'm glad to be here. Welcome, everyone. That's all I've got.
Well, thank you, Carl. I'm still trying to collect myself after the game last night, so thanks. Appreciate that. So let's go to appreciate your insights and awareness and ability to be able to go into this discussion with an open mind. Next slide, please. Thank you. So just briefly, many of the folks who are on the call probably know of Dr. Hotez. We are delighted to have Dr. Hotez in our backyard here. He is a world expert, American scientist, pediatrician, advocate in the fields of global health, vaccinology, and neglected tropical disease control. He serves as the founding dean of the National School of Tropical Medicine, professor of pediatrics and molecular virology and microbiology at Baylor College of Medicine. He's also the director of Texas Children's Hospital Center for Vaccine Development and Texas Children's Hospital Endowed Chair in Tropical Pediatrics. He's also the co-director of the Parasites Without Border, a global nonprofit organization with a focus of those suffering from parasitic diseases in subtropic environments. I want to turn the floor over to him, and he is going to take some time to talk about facts and fiction about COVID, and also will take some time at the beginning to at least tell us a bit about what we know so far about the Omicron variant. Dr. Hotez, please.
Well, thank you so much, Dr. Masudi. It's an honor to be linked with the U.S. Public Health Service, one of our nation's great organizations, and so proud of all the work, Dr. Masudi, that you and your team are doing here in this region, and appreciate all of your service. For full disclosure, I'm also a Houston Texans fan, and it's been a rough year for us, but hope springs eternal for next year. Let me share my slides. Hopefully that all works. I'll just leave it to the others to say, yes, that works. I guess people can see it. Good. So I'm just going to try to talk fairly briefly and kind of give you a general overview of some of the vaccine science and also something about the misinformation. So let me tell you a little bit about myself. I'm a professor of pediatrics and molecular virology at Baylor College of Medicine and Texas Children's Hospital in Houston, part of our large, massive Texas Medical Center. I was born in Hartford, Connecticut. I'm the parent of 4 adult children, and I'm basically a working scientist helping to lead a group that develops new vaccines, mostly for diseases of poverty, parasitic infections, such as Chagas disease and schistosomiasis disease that are particularly endemic in low and middle income countries in Africa, Asia, and Latin America. And I've been doing this for 40 years. And then around 10 years ago, we adopted a coronavirus vaccine program in collaboration with the New York Blood Center and the University of Texas Medical Branch at Galveston. And because they were orphaned as well back then. And that actually brings us to the first talking point, because people think vaccines were rushed, and they don't realize that it's at least a decade of research and development, including our group, that showed that the spike protein is a target of the virus, how you deliver the spike protein, how you induce virus neutralizing antibodies. And we did that for SARS and MERS. And then when the COVID-19 sequence came along, we're able to pivot and make that. And I tell that story because people need to understand that the coronavirus vaccine ecosystem is not rapid and quick. It's been around for a long time. And of course, now what we've been experiencing is this Delta variant, which in this part of the country, in the South and Texas, has really been devastating. So this Delta wave, at least in this part of the country, over the summer and into the fall, has been the worst of all. So we initially had the big Delta wave earlier in the year, and then that got replaced with the Delta wave. And this is where we are at globally now. We're hitting 50 million reported cases, and we're likely going to hit 800,000 deaths any day now. So it's been so awful. And I think for me, one of the worst aspects is this peak of cases and deaths over the summer and the fall, because it happened at a time when vaccines were widely available. So it happened because people made a terrible decision not to get vaccinated, and ultimately they lost their lives from COVID. So now we have pretty strong numbers in multiple states that 85 to 90% of these deaths were among the unvaccinated. So here are the numbers in Texas, for instance, where I am, and this is our Delta wave in terms of deaths. And 85%, this is reported by the Texas Department of State Health Services, 85% of the deaths were among the unvaccinated, 7% among the partially vaccinated, only 8% among the full vaccinated. So this is what's been killing people here in the state of Texas and in our region since June 1, tens of thousands of deaths, needless deaths. So in the case of Texas, the numbers are 20,000 deaths. And I can't stress that enough. And that's why when Dr. Massoudi in the U.S. Public Health Service gave me the opportunity to address everyone, I was thrilled at the opportunity, because I want to, if this is the one thing you need to take home, is the fact that since the summer, 20,000, 150,000 nationally, but 20,000 in Texas alone, 20,000 unvaccinated Texans needlessly lost their lives because they were either misinformed or defiant of getting vaccinated. None of these people had to lose their lives. And I don't even know what you call it anymore. We call it misinformation or disinformation. It's practically a form of self-immolation, and we've got to fix it. And if you detect a tinge of desperation in my voice, it's for real. I'm just so devastated by this massive and totally unnecessary loss of life here. So this writes out what I've just said. Since June 1, 150,000 unvaccinated Americans, including 20,000 Texans, have lost their lives from COVID. Almost all of those deaths preventable because vaccines are widely available. And this really goes to show the importance of countering vaccine misinformation and disinformation. And because that's not complicated enough, now we've got a new variant, a Delta variant, on the rise. Here in Harris County, we've had our first Omicron patient, and we're detecting Omicron in wastewater samples. It'll take a while before it becomes an important variant, but it'll happen eventually as we go well into the winter. So by next month, I would imagine Omicron is going to be a serious factor here. And it has some properties that are different from the Delta variant. Among them is the fact that it does have a lot of mutations in the spike protein, so that if you're not fully vaccinated and boosted, I think you're going to be highly vulnerable. So the ones who I expect to be disproportionately affected by Omicron are those individuals who've been infected and recovered, but have chosen not to get vaccinated on top of that. And so what we're talking about then are reinfections from Omicron. Why do I say that? Well, we're seeing this play out in South Africa right now. We're seeing lots of Omicron reinfections among those individuals who are infected and recovered, then chosen not to get vaccinated. If you get vaccinated on top of that, the level of virus neutralizing antibody gets really high, and I think those individuals are going to be able to have a lot of resilience against Omicron. The other population I see that are going to be vulnerable to Omicron are those who've gotten 2 doses of the vaccine, but have had of the Pfizer BioNTech vaccine or the Moderna mRNA vaccine, but who have had waning immunity and have not gotten their 3rd immunization. I think they are also going to be pretty susceptible to Omicron. So that's the message. If you're infected and recovered, get vaccinated. If you've gotten 2 doses, get that 3rd dose, and don't forget to vaccinate your kids. Your kids over the age of 5 are eligible. And during this last Delta wave, we saw a lot of children get sick across Texas and here in the South, and including pediatric ICU admissions, and I'll talk about that. So I think then the 3 key take-home points are: 1, for the mRNA, if you get your 3rd dose when eligible, because this is why when you get your first 2 doses, you get a primary immune response, it fades, and then when you get boosted, that's what gives you the big bump in virus neutralizing antibodies, 30 to 40 fold higher. And the hope is that it stays up, and and there's some evidence that it does. We don't know for how long exactly, but getting that third immunization is paramount. Second, infection and recovery results only in partial immunity. Get vaccinated on top of it. So in South Africa now, reinfections are three times more likely with the Omicron COVID-19 variant. And then finally, the critical nature of vaccinating your children. So what I want to do is, before I finish, is quickly go through some of the points that have been put out there from the disinformation, misinformation empire. And now I've written a couple of articles in collaboration with colleagues. So I'm co-heading a Lancet Commission on COVID-19 vaccines and therapeutics. This is an international commission, and we've recently published this year a paper that came out in eClinical Medicine, which is one of the Lancet family of journals, where we try to provide a brief primer to assist healthcare providers in correcting a growing body of misinformation. And what we basically did was to informally look at some of the key false talking points that we're hearing from anti-vaccine groups and try to correct that misinformation. And so let's go through a few of them. One, that COVID vaccines were rushed. And so there's a study that's come out now that the average vaccine timeline requires a 10-year timeline beginning with the preclinical phase. And it's true that research on COVID-19 vaccines did not first begin, we first heard about it in 2020, but it really builds on at least a decade of previous research on coronaviruses, leading to proof of concept for the spike protein as a lead target. And so the point is, we'd been working on coronaviruses for 10 years, which is actually about the right timeline that we've seen for other vaccines. And the only difference is when from China, when they put up the SARS-2 coronavirus genomic sequence on a preprint server in January 2020, it was possible to quickly adapt all of our previous vaccine concepts, showing that the spike protein is a target, how to deliver the spike protein, how to measure virus neutralizing antibodies to this new virus pathogen. And I say that because, to disabuse people of the idea that somehow these arose like magic. Now, where did this come from? In part, it was because partly the pharma company CEOs and were sending out press releases. And what I say is, when a pharma company CEO sends out a press release, it's not meant for you or for me. It's meant for their shareholders. And in the past, that was okay. But in this, when everything's under the microscope, I think that helped cause a lot of damage. Bottom line, COVID vaccines were not rushed. Two, this myth of genetically modified humans. So one of the things the anti-vaccine groups have been doing is using the language of genetically modified organisms, GMO, and then adapting that to vaccines. And so something that's out there is because what they're saying is they're adopting the language from a genetically modified organisms, and they're saying that vaccination will insert foreign genes into our genome. In fact, that's simply not true. And the reason it's not true is because, if you remember from your high school biology, in the cell you have a nucleus, you have cytoplasm, and the mRNA that's delivered through the lipoprotein particles goes into your lipid nanoparticles, goes into your cytoplasm, not your nucleus, and then it's made into polypeptides. There was a paper put out by a group at MIT that has gotten some attention, where at the same time in a cell line, they'll overexpress reverse transcriptase or something called the line element, and they artificially create a situation where the RNA is made into DNA, which then could potentially be incorporated. But that's a very artificial condition. The bottom line is the mRNA is not getting into the nucleus. It's not causing genetically modified humans. And then you get an array of stuff that is just sort of crazy. And I think this is one of the, as Dr. Masudi says, the misinformation or disinformation. I define disinformation as deliberate intent. It varies, right? It varies from the seemingly plausible but not true. I think that's the toughest to combat, as he rightly points out, saying that vaccines were rushed. we can debunk that, but it sounds plausible, to the stuff that just sounds totally crazy. And this gets much more straightforward. So, claiming that it's the result of 5G mobile, or that they're using vaccines to insert microchips for purposes of tracking or surveillance, which is absolutely not true. There's no evidence for it, and it's just an absurd hypothesis. Another circulating fear is that COVID-19 vaccine trials might result in unintended consequences similar to the tragedy during the 1950s when the drug thalidomide was used to treat nausea in early pregnancy. The way you counteract that is to say, look, first of all, the clinical trials were large. I mean, as large as any clinical trial of a vaccine we've really ever had in modern history. I mean, 40,000, 60,000 participants. And remember, even after the clinical trial is done and the vaccine is either approved or released through emergency use authorization, it's not like we stop following it. The U.S. Public Health Service, the Food and Drug Administration, the CDC, the Centers for Disease Control, together have the most robust system of what's called pharmacovigilance the world has ever seen, meaning there's quite an elaborate system of vaccine monitoring that includes the VAERS reporting system, vaccine safety data link. There are about 4 or 5 parallel systems of monitoring. And the proof that it works is they can pick up very rare events, such as the 1 in 500,000 to 1 million cases of cerebral thrombosis from the adenovirus vectored vaccine from Johnson & Johnson. And we're able to identify a group that might be at risk. So the fact that they can pick up 1 in 1 million adverse events, I think, is a testament to the power of our government's pharmacovigilance and reporting system. Fetal abortions, this is one that comes up a fair amount. For the mRNA vaccines, not an issue at all. For the adenovirus vectored vaccines, and there are several of them, the AstraZeneca Oxford vaccine, the J&J, the CanSino Bio. The only one approved for use in the US is the J&J vaccine. What happened there was they do use a cell line from either the Percy 6 cell line or HEK cell lines that were derived from the kidney of an aborted fetus, one in the 1970s, one in 1985, and those cell lines are propagated over the last 50 years. The point is there's no fetal material in any of those, in any of these vaccines, and the cell lines have no remnants left of any kind of original fetal protein. It's not as if they're coming from aborted fetuses on a regular basis. It's one each for these vaccines, for different vaccines, and then the cell lines are propagated over a period of decades. So much so that the Vatican has come out with a very strong opinion paper that the benefits of these vaccines clearly outweigh the moral opposition to any vaccines that use these cell lines. And if you do have concerns about the adenovirus vectored vaccines, you can always go to the mRNA vaccines. We also, with my colleague Mary Elena Bottazzi, has been my science partner for the last 20 years, we wrote a second article in the Washington Post looking at some of the same, but also some different myths. And I'll just finish up with these. Infertility, this comes up a lot, concerns that the mRNA or adenovirus vectored vaccines cause infertility. The answer is no. There's no evidence, and there's even evidence to support that there is no link. All that was done here was the anti-vaccine groups simply copy-pasted their false claims that they tried to make for the HPV vaccine for cervical cancer and other cancers and glom it onto COVID vaccines. Bottom line, no association with infertility. Then there's this kind of myth out there that says if you're young and fit and healthy and go to the gym all the time, you don't need to get vaccinated. And it's simply not true. And we saw this play out in our terrible Delta wave over the summer and fall. Lots of young people, 30s, 40s, and up to in their 50s, in hospitals, in intensive care units, and COVID deaths in people with no underlying condition. The other point is the other myth that's kind of put out there is people quote only death rates. there are other things happening. And now we have a lot of evidence about long COVID, meaning symptoms lasting more than a year. The British Biobank study, where the National Health Service there has had access to 40,000 brain scans, MRIs of people pre-pandemic, and those who got COVID, they can bring them back to rescan them. And it's pretty frightening what you're seeing. We're seeing gray matter brain degeneration and a picture of cognitive decline that resembles individuals much older. So if you're young and healthy and fit, one, you could still be hospitalized, go to the ICU or worse, and you're still at high risk for getting long COVID and cognitive decline. And this is a time in your life when you're trying to get your first mortgage of your house, or take your SATs, or get your first job. This is not a time for you to get long COVID. Second, and I think this is the last myth, the claim that vaccines are actually inducing variants. Very important to point out, no, it's the other way around. Alpha arose out of an unvaccinated population in the UK in 2020 out of southern England. Delta rose out of an unvaccinated population in India in 2021. And Omicron arose out of an unvaccinated population in southern Africa. So it's when we allow large populations to go unvaccinated that the problems arise. And so I've been spending a lot of time trying to combat the misinformation. And I have another role as well, which is that I have 4 adult kids, including Rachel, who has autism and intellectual disabilities, and have been trying to fight this battle with anti-vaccine groups for 20 years, who initially claimed that vaccines cause autism. And this is my recent book, Preventing the Next Pandemic, Vaccine Diplomacy in a Time of Anti-Science, where I look at some of the big driving forces, social determinants, as well as climate change, behind the rise of disease that includes COVID-19. And so that COVID-19 is really more of a capstone event than something totally unusual, because we've been seeing the rise of epidemics for the last few years. But I'm going to focus on this one initially, the problem with anti-science. So the way the anti-vaccine movement has evolved or devolved is as follows. It began with false assertions claiming that vaccines cause autism or pervasive developmental disorder, and this included the measles, mumps, rubella vaccine and thimerosal vaccine. And after that was debunked, although that thread still seems to exist, it took on a political dimension starting in the 2010s, linked to this concept of health freedom, medical freedom, and now it's become a globalized movement. The point is, the anti-vaccine groups keep on changing their stripes, but all with the same intent to scare people into not getting vaccinated. So let's go through briefly 1.0, 2.0, 3.0, then I'll stop. So version 1.0, around this claim that vaccines cause autism, it started with a paper that was retracted by the Lancet that claimed the measles, mumps, rubella vaccine had the ability to cause autism. And there were large cohort studies that followed showing that kids who got the MMR vaccine, the measles, mumps, rubella vaccine, were no more likely to become autistic than kids who didn't, or that kids on the autism spectrum were no more likely to have gotten MMR than not. And after that came out, anti-vaccine groups started saying, okay, well, if it's not the MMR vaccine, it must be the thimerosal preservative that's in vaccine. And that was similarly debunked with similar types of studies. And we kept on getting into the situation where, as the scientific community responded, the goalpost would move and a new assertion would come up. Then it was spacing of vaccines or alum in vaccines. And then they, even in some cases, pivoted away from autism altogether to claiming it was the HPV vaccine that was causing infertility and autoimmunity. And that's where the current assertion about the COVID-19 vaccine comes from. The point is, none of these things are true. And my role, again, was having 4 adult kids, including Rachel, who has autism and intellectual disabilities. I tell the story of Rachel. We live in the Montrose neighborhood of Houston, Texas. I think this is Velvet Taco here, pre-pandemic, and wrote the book with the straightforward title, Vaccines Did Not Cause Rachel's Autism, where we go into detail showing the scientific evidence there's no link, and also what autism is. And they talk about doing whole exome sequencing through the Baylor Genetics Department, which is a specialty department devoted to this, on myself and my wife Ann and Rachel, and identifying an autism gene similar to the 100 others that have been identified, all expressed in early fetal brain development, all involved in neuronal connections. And in this case, it provides an alternative narrative. The anti-vaccine groups didn't like that very much. They began calling me the OG villain, which I had to look up. It means original gangster villain. And so we had some impact on debunking that. But unfortunately, what happened here in Texas was to re-energize. They glommed themselves on to the far right and political extremism, even creating a political action committee, an anti-vaccine political action committee. And now we're up to more than 70,000 kids denied access to their vaccinations. And it's particularly strong in the suburbs of Austin and up in some of the North Texas counties. And it's very powerful. They've got funding, they get PAC money, they get political financing. So these are not grassroots or mom and pop groups. These are well-organized, well-funded political entities now. And unfortunately, under this banner of health freedom, medical freedom, the U.S. and Texas is starting to export this. So for the first time, we've had now anti-vaccine protests in Canada, in Vancouver and Ottawa, elsewhere in Ontario, using that same kind of phony health freedom, medical freedom language, and even in protests in Berlin and Paris, and it's New York Times and BBC have reported it's been even linked to QAnon and political extremism on the far right. So we have our hands full, and how the anti-vaccine movement has become a very powerful political movement and fills up our internet with a lot of fake talking points. And it's hard to keep up because every time you think you've debunked most of them, a few others will always arise. But I think we have to keep on trying because, as I say, the consequences now, 20,000 unvaccinated Texans have lost their lives needlessly since June 1, and we have another Delta wave / Omicron wave coming. So I'll stop there and turn it over to you, Captain Masudi.
Thank you so much, Dr. Hotez. Really appreciate your insights and your vast knowledge in this area. And yes, you're absolutely right. So I think we do need to keep on this and appreciate your wise words. So if we can have maybe the next slide, please. Great. So our next speaker, Dr. Joseph Cantor, is the State Health Officer, Medical Director from Louisiana Department of Health. Dr. Cantor, as the State Health Officer and Medical Director, serves as the top medical official for Louisiana Department of Health, consulting on issues relating to policy, programmatic implementation, quality, and accessibility of care, health equity, emergency preparedness, infection control, and bearing responsibility for enforcing the state's sanitary code. His previous state roles have included Assistant State Health Officer, Interim Assistant Secretary, and Regional Medical Director. Prior to joining Louisiana Department of Health, Dr. Cantor served as a Director of Health for the City of New Orleans and led Mayor Mitch Landrieu's comprehensive opioid mitigation strategy, which included issuing the first in the state standing order for naloxone, equipping the New Orleans Police Department with the reversal medication, increasing availability of this medication-assisted treatment, promoting harm reduction services, and initiating a citywide effort to reduce stigma of addictive disorders. He's a practicing board-certified emergency physician, so he knows very well what is actually going on, what's going on the streets. Prior medical director of the healthcare for the homeless clinic. Dr. Cantor cares for a diverse spectrum of patients in the New Orleans area, including some of the most vulnerable in our community. He's committed, academic, and works closely with students, residents, and other learners. Primary interests are expanding access to patient-centered care, promoting health equity, creating efficiencies in systems of health while protecting vulnerable populations. We're going to have Dr. Cantor talk today, not just about a bit about Omicron and some of the cases that we're seeing in Louisiana, but also talking about the future of past COVID. Specifically, Dr. Cantor, along with a number of other health officers, recently, back in September 29th, testified in front of the House subcommittee on September 29th. Representative James Clyburn, chairman of the select subcommittee on a coronavirus crisis, held this remote in-person hearing examining challenges facing the nation's state and local public health departments as they respond to the coronavirus pandemic. The hearing was going to address the dangerous politicization of public health and identify ways to rebuild and strengthen the country's public health infrastructure. And so Dr. Cantor was the state health officer, along with two other local state health officers, health officers who testified. And I think that was very helpful for us to be able to hear from you about your experiences as to how we can move on from COVID and what lessons learned can be applied to other pressing issues. So Dr. Cantor, the floor is yours.
Thanks so much, Dr. Masodi. I am Joe Cantor. I'm the state health officer for Louisiana, and I'll do my best to give some perspective of how these issues play out when implemented and implemented programmatically on a state level. My thanks to Dr. Masodi for pulling this webinar together, even if you are a Steelers fan. My sincerest thanks to Dr. Hotez. Dr. Hotez has dedicated his professional efforts right now to combating this type of myths and disinformation. And it's not easy work. And he really puts himself out there and makes himself vulnerable to personal attacks. People get quite ugly when you engage on this level. So, I mean, I just wanted to mention how much respect I have for him and the work he's doing. He really is a source of truth in these really confusing times right now. And I'm honored to be here on the webinar with him. And I wanted to thank also Surgeon General Vivek Murthy for really shining the spotlight from his position on myths and disinformation. I think, this is no longer just a distraction. And unfortunately, it's not just fringe anymore. And when you have 780,000 odd deaths nationally from this virus, you have to look critically at the ill effects that myths and disinformation are having on people. They are legitimately costing lives. And when you look at it from that perspective, I think we're all obligated to act. When people stay silent, when these type of myths are propagated, it ends up hurting people because they get amplified without any recourse. So I think we all need to play more in this space at various levels, because the anti-vax movement here, the anti-science movement, has only become more sophisticated and better funded throughout this pandemic. And it really is scary. Ultimately, it's scary because families get caught in the middle and they're suffering from it. One example that I shared with the team here just before we went live on this webinar, we had a committee hearing in our legislature in Louisiana earlier this week. And two of the leading national anti-vax activists were not only there, not only allowed to speak, but they were essentially rolled out on a red carpet, given spotlight. One of them came with a bunch of posters and basically gave a lecture for a half an hour in this very formal setting, giving a lot of weight to the disinformation that he was spreading. And for people that are not immersed in this work, which is the majority of Americans, it's easy to get fooled. You have a slick presentation, slick slides, data that's cherry-picked and taken out of context. And it's easy to pull the wool over someone's eyes once or twice doing that. You have to look back at these individuals or these movements, and as Dr. Hotez mentioned, they have brought the same type of deliberate disinformation to vaccines of various types going back decades. It's the same play, just a different quarter in the ballgame. But most people don't know that. Most people hear the pitch. It's a slick pitch. It feeds into pre-existing conspiracy theories or notions of liberty. And it's easy to be fooled when people don't know the full history of what these movements are about and what type of things that they have said in the past that have already been resoundingly discredited. It's easy to fall in the trap, is the point I'm making. It's been even easier to fall in that trap with COVID because we're living in this pandemic real time. And everything, the past 21 months of this pandemic has been fast-paced and confusing. And particularly now with the Omicron variant emerging, there is a lot of uncertainty in that. For example, and Dr. Hotez hit on a few of these items, it appears that Omicron is more transmissible than the prevailing variants, including the Delta variant. How much more transmissible, we don't yet know. It appears that Omicron has some resistance to both the protections one gets from prior infection and also from vaccines. How much resistance, we don't exactly know. It doesn't appear that the Omicron variant is more virulent, meaning it doesn't appear that it's making people sicker than the prior prominent variants have been, although that's very, very preliminary, and there still is much more we have to learn about that. Bottom line, there still is a lot of uncertainty with Omicron. The anti-science and anti-vax movements have become experts at exploiting that uncertainty. I mean, we just need to be honest with people that when you're in a pandemic, the science is coming in real time, and you do the best job you can to accumulate and analyze the data you have available and turn that into actionable recommendations. It doesn't mean that it's 100% perfect. And it doesn't mean that if you learn something new a month later, that you're not going to go back and incorporate that new information and revise your recommendations. That's really what the scientific process means. But in that is uncertainty that these movements have become very apt at exploiting and seeding doubt deliberately into people's minds. I'll tell you some of the things that have worked well for us in trying to combat this, and then some of the things that we need help on. First, I think we have to recognize that it is completely normal and expected for individuals and families to have questions. Look, I mean, again, everything with COVID has been fast-paced. It's been confusing. We've never been here before, at least not in our lifetime, to this degree. And people have questions, all types of questions that might seem silly to us, questions that might be the same exact questions that we have, but everyone has questions. So the first thing is to recognize that that's normal and encourage, actually. We need to honor the questions that people have, no matter what type of questions those are, or how many times we've answered it, or even if it seems silly. We need to honor people's questions and reassure them that having questions, having doubts right now is normal. It's very, very human, given the degree of uncertainty and particularly the degree of trauma that we've all endured. We need to bring good scientific, data-backed answers to people's questions in a way that honors their question and empathizes with them. We can never be judgmental when people ask questions about anything, particularly vaccines right now. On the same token, and perhaps the flip side of that, we have to push back very hard against actors who are deliberately spreading disinformation. There's a lot of misinformation out there, and that's the type of information that is not intentionally misleading. It's erroneous things being spread perhaps innocently on social media or from friend to friend or family member to family member. And for those type of issues, it's helpful to bring good data and science to those answers. But when people deliberately try and spread disinformation, and those are some of the actors that we've been talking about and Dr. Hotez kind of reviewed, we need to push back on that very hard, both on the point that's being made and on the underlying movements that are trying to exploit this uncertain situation. And I'll tell you, the public health workforce right now needs help with that. We're just traditionally not geared up for this level of engagement. The disinformation is being spread on media platforms that the traditional public health infrastructure has been relatively slow to fully engage with. We've been relatively slow to fully take advantage of social media. We've been relatively slow to fully enlist outside partners, influencers, people that can really help drive the message that are not traditional partners of public health. We've been a little bit slow with that. We've caught up a decent amount throughout this pandemic, but traditionally it's not been our strength. We need help engaging with that. I think the things that have worked well for us, and there are plenty of things that have not worked well, is that the more that we have been able to engage people where they are, wherever they are, we have found that successful. And that can mean physically where they are, it can mean going to a church, a community center, bringing a vaccine event or a Q&A session or a town hall type forum deep into neighborhoods to where people feel comfortable going where they already go. We have found that to be successful. And also kind of metaphorically where they are. If social media is the place where an individual typically gets their information, well, that's where we need to engage. If trusted messengers, if community leaders, if faith-based leaders are the place that a person typically gets their information, that's where we need to engage. We can't be high and mighty and proud and kind of stick to an ivory tower or stick to formal press conferences. We really have to be meeting people where they are at. The public health workforce needs a lot of help with this. Again, it's not something that we've traditionally been all that good at. We need to be engaging in new types of partners, and particularly partners that have credibility amongst the populations that we're trying to reach. You know, as a state health officer for Louisiana, I need to be humble and recognize that I am not the best messenger for everyone in my state. I'm not the best messenger for most people in my state, but somebody is for any particular person in Louisiana. And it's my team's job to find those individuals, empower them, give them the resources and the tools they need to drive the message home and really connect with people and help answer their questions. One thing that we tried to make clear when we did offer the testimony to the U.S. House Committee a couple months ago is public health departments need relaxed funding streams to be able to do this. Typically, the funding that public health departments receive is highly regimented. It's program specific. It doesn't leave a lot of room to build capacity. It doesn't leave a lot of room to do anything other than the specific grant with which the funding is tied to. A very restrictive model of funding. So when we spoke to the House Committee, we advocated that in order to engage on this new battlefield, if you will, health departments need more flexible funding. They have to be able to build capacity. They have to be able to divert resources quickly where there's a need. And that simply wasn't an option for most departments on the current and prior model where funding is tied specifically to a grant or specifically to a disease or to a program. So we made the case that the more funding can be flexible for health departments, the more it would allow health departments to engage in these different elements, to enlist and empower outside partners and kind of meet this issue really where it needs to be met. It's not, again, traditionally what health departments have really done particularly well, but we have to. Because if we're not meeting people where they're at, if we're not providing information in a way that's meaningful to them, in a way that they will hear it and understand it and trust it, then we're going to lose this battle. Because again, the entities that are deliberately trying to spread disinformation, they've gotten more sophisticated, and so do we need to as well. Dr. Masudi, I'm going to pause there, but I'm looking forward to a good Q&A session coming up. Dr. Masudi.
Thank you so much. I appreciate it. And I think that what you were saying is really resounding. I think that you weren't just necessarily saying this for Louisiana. I think that unfortunately, this type of funding, this inconsistent funding is unfortunately there for all state and local health departments, and that this issue really needs to be used for everyone to take heed and help us all in addressing COVID or any kind of future health risks. So I think that one thing I want to stress importance is that we put it in the chat. We're trying as best as possible to monitor the questions that are coming in. So the next thing is we're going to open up right now. Bill, if you want to go to the next slide, is for the Q&A now. If you could please make sure you send your questions to the host and panelists so we can make sure to capture that. We know that there have been some questions that have come through already. Also, what we wanted to make sure to do is that Ella has already also put a link to an evaluation form. So folks will send that out as well afterwards to those who have registered and have attended. We want to make sure to hear from you. In other words, what did you like about this webinar? How can we make this better? And also hear from you about what other types of topics would you like to hear about in the future, about other needs that you have. So I think that, let's see, Carl, if you're available, if you wanted to also come on. And so now I think that maybe we can look at the questions and Dr. Hotez and Dr. Cantor.
Can you hear me?
Yes, I can hear you.
Yes, I can.
Great. So first and foremost, to our presenters, and especially to you, my partner, Mehran Masudi, thank you, thank you, thank you. Only because they were aware that this was going to be a good cop, bad cop kind of a presentation. I don't know if I'm the good cop or the bad cop, depending on where you sit. But the thing I'm going to say to everybody on this call is please evaluate. I'm going to be looking at long-term COVID. It's one of the things I came away with. I'm going to be looking at the fact that the pharmaceuticals notes to investors are not, what I gathered, a medical expert. They are dealing with money. Money is, we know, the root of all evil. I do think that we need to make sure we're looking at the questions, and the questions I'm submitting are coming from the people that are acknowledged to be antivirus, anti-mask, anti-vaccine groups. So I'm going to give you, would you like them one at a time, or can I just give you all three and you can pick what you want to answer to?
I guess one at a time, or I don't care, whatever you want. Doesn't matter.
Well, let me give you the three.
There's nothing you can ask me that I haven't heard before.
Maybe if we can just go one at a time, Carl, it might just be best that we can just make sure that if there are things that maybe Dr. Cantor can address maybe after Dr. Hotez, and we can come back to any of the other ones that you might have, then we can keep track of that. Thanks.
Well, I'll try to move fast to save time for everyone. But the one is from those people that are dealing with trust. I've got one from a person that says that they are dealing with a loss of hair. They're telling people that it'll take 6 to 12 months for that symptom to go away, and wanted to know what we had to say about that question. Somebody want to answer that?
Well, I mean, alopecia, hair loss is I'm not aware has been identified as linked in any way to getting vaccinated. There are, if you look at the causes of alopecia, hair loss, it's a pretty extensive laundry list, and you have to remember that when you're vaccinating 200 million Americans, which are the number of Americans who've been vaccinated, there are 200 million Americans who are experiencing an array of illnesses and symptoms, but they're not attributed to the vaccine. So as far as we know, alopecia has not been linked to getting vaccinated, and it's not like we're not looking. Everything in the VAERS system doesn't establish causation. They just look at anything temporarily related, whether it's a car accident or you name it. But so far, there's no evidence that I've seen that alopecia hair loss is related to vaccination.
Thank you, Dr. Holtz. Next question comes from a very well-known LinkedIn influencer that has millions and millions of followers. Their question is simply this: why is it obligatory to take a vaccine, and I'm healthy, I don't have a problem? I don't see the logic.
I'll let Dr. Cantor start, and I'll chip in.
Yeah,
Or Dr. Masudi.
Yeah, and Carl, that's really a great question, because we hear that a lot, and I think on the one hand, you do need to be honest with people and let people know, listen, the odds of suffering severe consequences from COVID-19 typically go up as you get older. That's just what the data shows, but that doesn't mean it's absolute. You know, there's been about 1,000 pediatric deaths in this country from COVID-19, and if that's one of your kids, then that's 100%. Those odds mean nothing if it is your kids. That says nothing about also severe disease. We've had a lot of people that have had multisystem inflammatory syndrome in children. And it says nothing at all about long COVID, which is an area that we really don't fully understand yet. So it really does affect people. And I'll tell also, we have plenty of cases of people that had very, very mild courses of COVID, sometimes even asymptomatic initially, and still developed debilitating long COVID symptoms: brain fog, persistent cough, persistent lethargy. Those things are real, and they still remain poorly understood. So even though your chance of dying is less with COVID if you are younger, number one, that's not absolute. Number two, it doesn't mean that you're not going to be affected in one way or another. And number three, it also doesn't mean that getting COVID is a good thing, because you can get those effects, you can spread it to other people, and vaccines help break that cycle of transmission. They make it about 6 times less likely that you're going to be infected in the first place. So I think all those things, it's still a pretty good sell to get it, even if you're not in the age group that's going to suffer the worst of the worst consequences.
And I'll just add to that, in addition to protecting yourself, it does have that property at certain times of reducing transmission to others. So for instance, right after you get your second dose, there's strong data out of Israel that showed a 90% reduction in asymptomatic transmission. So you're less likely to pass it on to other people. You're less likely to pass it on to other people's kids. So it does diminish transmission in the community. It's true that as time goes by, after 2 doses, you lose some of that function, but that's all restored again when you give that 3rd dose. That once again, it has the ability to lower the amount of virus in your shedding from your nose and mouth. And the reason that happens is there's so much virus neutralizing antibody that it gets in the mucous membranes of your nose and mouth, so it's stopping virus shedding. The unknown is whether that's still going to hold up for Omicron, and that's something we're looking for now. But for the existing virus lineages, it's having not only an effect on reducing the likelihood you'll get sick, you'll get long COVID, you'll go to the hospital, you'll go to the ICU or worse, but it also has a big impact on reducing transmission as well.
Thank you both for your response. I'm going to close, and after this next question, Captain Masudi, you can move on. But I want to thank everyone before this last question for you qualified experts. I know Dr. Hotez has been involved in vaccinations always back to SARS. And some things we didn't learn at SARS, we're learning now. And we have to understand this question relates to retracted statements. And Dr. Cantor, I thank you for already addressing it in what you called real time. We've got to understand that the knowledge continues to evolve. But here's the question: how come no one talks about herbs, minerals, and the body's ability to be a master healer? Instead, we're dealing with synthetics. And then part 2 of this same question refers to all the elite athletes that are dying according to this. Now, I don't know what all represents. So maybe you guys, doctors, can address this, because I only know of one, but it may be bigger than I think it is. So again, How come we don't deal with the fact that the body is a master healer and we can feed ourselves, eat ourselves, and exercise ourselves into staying healthy? Thank you guys for being here.
Thanks, Carl. I'll go first and then turn it over to Dr. Hotez. COVID is a formidable enemy. is I think the bottom line for a lot of people. And I've heard a similar question raised with regards to particular like homeopathic treatments like zinc or sometimes vitamin C, and other quote unquote natural protections. I mean, I'll say this. In medicine, the way that we evaluate any treatment is we study it and we see if it works or doesn't work. That's what being data-driven means, is you study something and you see if it's effective and safe or not. And there are a lot of things that we think might work and you study them and they don't. And there are some things that you don't have a lot of expectations going to work and you study it and it does. That's the only way you get to the true answer in science and medicine. You can never just rely on antidotes. So with things like zinc or vitamin C or other quote unquote treatments that have not been really recommended, all you can do is study it. And if the data doesn't show that's effective, then that has to be the recommendation. And that's what's been done with those things. There's really not been any evidence to suggest that taking a zinc supplement,
I think he froze up a bit.
Other snake oil treatment, hydroxychloroquine and ivermectin, you just have to study it and you have to trust the data when you get it back. Dr. Hotez,
well, what I'd add to it is, yes, of course, the body's a master healer, but it's imperfect. It's an imperfect healer, and it's not. And taking care of yourself or taking nutritional supplements is still not a substitute for getting virus neutralizing antibodies from a vaccine. Look, 300 million people died of smallpox in the 20th century until the vaccine came along, and now it's been eradicated. And same with COVID-19 vaccines. 85% of the deaths are among the unvaccinated. And so even if you're young and fit and healthy and doing all the things you can to max out your body's natural healing processes, it's still missing one piece, and that is the virus neutralizing antibodies from the vaccine. So lots of healthy, fit people who take care of themselves are losing their lives to COVID. And that's the one added piece that you can benefit from by getting the vaccine, those virus neutralizing antibodies.
Thank you. I think that we're running out of time, so I'm going to try to quickly go through some of these questions, maybe as they say, sort of like in the lightning rounds, please, Dr. Cantor and Dr. Hotez. So, and I think that we've tried to answer some of the questions on the chat. So for example, some of the questions were asking about why are the Moderna vaccines, for example, not approved yet or given for the adolescents. And I think that what we said is we put the CDC link on there to talk about that, but nevertheless, it's on there. And I think one question said, if we have reduced immunity due to time elapsed between first and second COVID vaccine dose, but it's not been 6 months since the second dose, should we get the booster early?
Yeah, it depends on what your specific situation is. If you got Johnson & Johnson, the 1-dose series, and the recommendation now is to get boosted at 2 months out, 2 months or more out. If you got Pfizer or Moderna, if you have a condition that renders you moderately or severely immunosuppressed, and folks like this usually know who they are on chemotherapy, they have other conditions that really impair their immune system, then it is recommended to get a 3rd dose earlier. If not, the recommendation now is to wait till 6 months out. That's what has been studied. And I think you usually go with what's been studied and what we know the most information about.
Great, thank you. Also, there's some questions that have come out with about the Johnson & Johnson. We talked about the 2 mRNA vaccines, but this specifically about the Johnson & Johnson. Any thoughts on the J&J? What booster is recommended?
Well, it depends what you mean by booster. If you've gotten a single dose of J&J, there are advantages to getting the second dose of J&J. I know there's some studies. There was one published preprint, not published, but a preprint put up that said the virus neutralizing antibodies weren't as high as getting a Pfizer or Moderna booster. But the way the kinetics of the antibodies are is that it has a little more of a lag, but once it gets up a little bit later, then it could be quite durable. And there's some evidence even that the length of protection, the durability of protection, might even be greater with the J&J vaccine, the 2 doses of the J&J vaccine, than the mRNA series. So they each vaccine, Moderna, Pfizer, J&J, has advantages and disadvantages. The one concern that we have with the J&J, of course, is that very rare cerebral thrombotic event. So I've been saying if you have a condition that puts you at greater risk of thrombotic events, including pregnancy or on birth control, you might want to go with the mRNA, but that's still a soft call because those very rare events still seem to occur more with the first dose than the second dose.
Thank you. And also there were some questions about the recording and when it be shared and or on the website. The answer is both. We're recording this and we can also share it as well as having it be available on the website. It'll be on the CCRC website, but we'll go over that after closing through the slides. Let's see, there are some studies that are early and ongoing, but are there any reliable statistics regarding the long COVID at this time?
Well, we're still learning quite a bit about it. And I mentioned the biobank study, and that was very concerning to me that it's association with gray matter, brain degeneration, and cognitive decline. How far down that goes in terms of age, I don't think we really understand. And we're just learning so much about the mechanisms of long COVID and some very interesting studies on microglial activation, in terms of its impact on the brain or autoantibodies. I actually think that those studies are going to also shed a lot of light on things like chronic fatigue syndrome and fibromyalgia. So we'll be able to use COVID to learn more about other disease processes. But those are 2 of the biggest concerns. And I think, the big unknown is what's the impact of long COVID on kids. The Great Ormond Street Hospital in London has done an analysis suggest that 1 in 7 kids has long COVID symptoms lasting more than a year. And that's another important reason to get kids vaccinated. What we don't know is what the neurocognitive consequences over a long-term period are. And I think it's going to be very important for the National Institutes of Health, National Institutes of Neurologic Disorders, and National Institutes of Mental Health to really look at this in more detail. And I know that those studies are underway.
Yeah, I completely agree. It's still relatively uncertain. Our understanding is far from complete on this, and it's poorly quantified. It doesn't, when you go on to, for example, the CDC's dashboard to look at how many cases or deaths there are in the country or a state, it typically doesn't show you how many long COVID cases there are because we really don't know. And so for people that think
and there's a lot of different, and the case definitions are all over the place. So that adds to so you get numbers, 1 in 7, some say as many as 50%. So and that's probably because the case definitions are shifting. So we really need to fine tune that.
Yeah. So, I mean, if you're trying to get a picture of the toll of COVID, in a country or in a state or an area, you typically don't even get real information on what long COVID is, but it's impacting people. It's something people need to realize. If people think that COVID's not a real problem for them for one reason or another, I would disagree first and foremost, but also they're probably not even considering these kind of subacute longer effects like long COVID.
I want to, I wish we could stay on longer. I really do appreciate all of your time. It's been an amazing experience just listening to both of you talk, and wish we could be able, unfortunately, there are lots more questions that are on here that we just don't simply have enough time to address, and lots of great questions. But I want to maybe go on to with our few closing remarks at the end. Please, Bill. So again, as we did say, is that we're going to provide, along with the recording, much of this in terms of the myths that were suggested and other updated events and information that were discussed. We're going to provide that in terms of a resource toolkit, and we will have that for you and after the webinar. And here's the link for the Surgeon General's toolkit. And we also certainly appreciate, next slide, please. And so the webinar is really helpful for us to know if this was something that was useful. Was this meeting the needs of what you of the information that you use? And so the survey that was sent out to you, if you could please complete that and send it back, we would really appreciate that, and let us know if there were things that you liked, that things you could help us improve, and also suggestions for other topics. And then also here's our address, our website, as well as if you have any follow-up questions, our email address. And before signing off, one last time, Carl, if you have any final words before we say goodbye.
Hello. Again, all I really have to say is thank you. Captain Masudi, particularly, I want to thank you for allowing us to present a program that allows people to offer their feedback. I do want to let everyone know, as I said earlier, this program will be rebroadcast many times. And if it's okay, CCRC will gladly refer any other questions that were not answered today to the proper sources so that we can communication, because we believe at CCRC in silo busting. If we don't talk to each other, we'll never understand the real truth. And I believe the truth is what sets you free. Thank you again, everyone.
Again, thank you so much to our speakers and Mr. Berry. And thank you for all of you out there, all the hard work that you're doing. And again, if there are any questions, please feel free to reach out to us. And again, have a great day and great weekend. Bye-bye.